All right, committee, welcome back. Starting a little bit late, but next on our agenda is long-term care issues and concerns. I had a couple people reach out about this topic. And so those of you new to the interim process, you can't ask for any bill drafts at our last meeting and still get them to be committee bills. So this is primarily a placeholder for any kind of issues that this committee wants to explore that would take statutory changes. But we are going to just maybe get an overview of long-term care issues in general. And then based on the discussion, if there are some places we need to move forward statutorily, we'll do that. So let's welcome Director Johansson and Mr. Fuchs to talk on behalf of the Department of Health on long-term care.
Thank you, Mr. Chairman, members of the committee. Again, Stephan Johansson with the Wyoming Department of Health. As background, back in 2017, we completed a study of the aging population in Wyoming. And this is basically an update to that. And what that study entailed, very broadly speaking, were demographic projections of our aging population in Wyoming, of which Wyoming is one of the fastest rapidly aging states. The reason that's significant, as you all know, from a state policy perspective and Department of Health, is that Wyoming Medicaid is a significant payer for long-term care, both through our home and community-based services, as well as folks who require nursing home level of care. In fact, Wyoming pays approximately 65 to 70% of all nursing home bed days in Wyoming. So because of the cost of that care and our long-term care and aging population demographic issues, we had provided that to the legislature about 5 or 6 years ago and thought it would be prudent, given your topic of the aging population and long-term care, to give you an update on where we stand with those demographic projections and what we see in terms of utilization and cost projections in the Department of Health and Medicaid. Much of this slide deck that you have or should have from the Department of Health, you can use as reference material. We won't hit everything today in the interest of time, but I'll ask Mr. Fuchs to go through kind of the highlights of this presentation and give you a sense, again, from the policy side of where we think the state is heading in terms of our demographics and our utilization on Department of Health programs. Mr. Chairman, if it's okay with you, I'll hand that over to Franz.
Certainly, and just making sure someone's running the presentation. Is that you, Mr. Fuchs? It just hasn't popped up online exactly correctly yet. Oh. No problem. Sure, LSO. Those people online, we're working in that presentation live, but we're going to have Mr. Fuchs start speaking and then it'll be loaded up as he goes. Go ahead, Franz.
So thank you, Mr. Chairman, members of the Joint Labor Health and Social Service Committee. My name is Franz Fuchs. I'm Policy Analyst, Department of Health. I'll go through these slides real quick with the main takeaways. First, starting on those population pyramids, you might remember from 7th grade geography what a population pyramid is, but you can kind of see that, you know, from 1990 to 2040, our population is becoming less like a pyramid and more like a rectangle, meaning we are sort of an aging society. Is that older demographic you see highlighted in red? That's the baby boom generation, sort of moving up every decade into older and older demographics. The next slide kind of shows a different view of that. So looking on the left panel, you see the aggregate kind of kids at the bottom, middle age, 18 to 65 in the middle, and then the three older demographics, 65 to 75, and so on at the top. And you can kind of see how that Wyoming's population will, stabilize roughly around 600,000 folks, but will grow increasingly older. On the right, you see what we call the dependency ratio, which is the number of people that are 75 or older per working age adult. So it's basically the ratio of those top two demographics to that middle blue demographic. And as you can see, this is kind of what they call the silver tsunami. We're sort of at the bottom of that hill right now. In around 2020, we're climbing that hill and it should level off by 2040. But this is the big demographic shift that's really driving all these projections and really what the concern is when you hear that in the news. That dependency ratio varies by county. You can see on the small multiples. Some counties are going to be very similar to the state average, like Laramie County and Natrona County. Others, like Sublet, were below the state average, but their dependency ratio will dramatically increase well past the state average. So those counties may find themselves under some more unique stress compared to the rest of the state when it comes to workforce, because the dependency ratio not only represents the number of taxpayers per older adult, but also the number of caregivers and number of unpaid caregivers. So both on the nursing home workforce standpoint and unpaid standpoint, it creates stress in the system. In addition to growing older, we also are growing sicker as a society. The next slide shows the burden of chronic disease. So 65-year-olds, for example, in the light beige on the left panel, had an average number of 2 out of 8 chronic conditions in 2005. And now 65-year-olds have around 2.5 chronic conditions. So there's this measurable increase over time. And even controlling for the demographics, those individual demographics are getting increasingly sick. Yes. Oh, sorry. Ms. Chairman, you have a question from.
Thank you, Mr. Chair. Franz, always enjoy your presentations. You're saying we're growing older, which I agree with, and sicker. What are we growing sick of or with?
Mr. Chairman, Senator Hutchings, possibly this presentation, but the scale on the y-axis represents a count of 8 chronic conditions that are things like high blood pressure, heart disease, cancer, arthritis. They're very generally worded in the survey, so I can't say it's rheumatoid arthritis versus osteoarthritis, but those are kind of the general chronic long-term conditions that we're measuring on this survey. So the unfortunate reality is that most people will need some form of long-term care. So the next slide, you can kind of see it's around a 70% chance for people turning 65 today that will need some form of paid or unpaid long-term care. As far as paid, it's roughly a coin flip, with women having higher odds than men. But generally speaking, if you're entering a nursing home, you can expect an average around 2.5 years. That's kind of the average, right? But you can see that graph there shows the full distribution. So 2.5 years average may not be very meaningful when you're in that very tail, right? If you're in that far right tail, you're spending 10 or more years in a nursing home. That's the average isn't as meaningful. So we wanted to kind of show that whole distribution there. So ballpark, think of a coin flip as your base odds for needing it or not. And then if you do need it, if it lands heads, your expected length of stay is the that distribution there. And we compared it with a private study, PricewaterhouseCoopers, which is PwC in that acronym. They also, our distribution on Medicaid are looking at our own data compared pretty similarly to that distribution, but we wanted to show both just to kind of show you what the private sector was looking at as well.
Is it because life expectancy is longer for women, or what is that generally what accounts for that?
That's generally accurate. Yeah.
Okay.
And then you can see, of course, long-term care is expensive. This is the next slide. This comes from Genworth, their cost of care median in the nation. You can see the various levels of care there, going from around, for nursing home, 65,000 in 2004 up to over 108,000 today. Wyoming's medians are a little bit more centered. So our median long-term care nursing home is $91,000 a year for a private nursing home room. And unfortunately, many people are not really prepared for that, right, for retirement. So around half of people between 65 and 74 have no retirement savings whatsoever. And then those with some, you can see the median amounts were pretty small. And really, a lot of people just depend on Social Security at the end of the day. For those half that have no retirement savings, Social Security is a huge lifeline. Long-term care insurance is an option that many people might turn to. Only around 13% of people over 65 have long-term care insurance. You can see that market is stagnating. So the total number of covered lives had plateaued in around 2013, has been declining. So the number of new policies sold has really tanked in the last 10 years. And as a consequence, you can see their premiums have flattened off, but their incurred claims are dramatically keep increasing. So it remains sort of an open question whether this industry really will be very viable for the long term.
Any idea what's causing that? Just financial hardship?
Mr. Chairman, the truism is that if you need long-term care, or if you can afford long-term care insurance, you don't need it because you can self-insure. That's the truism. It tends to be fairly true. There's also the moral hazard of Medicaid. We're not going to lie there that, having Medicaid as a backstop, it reduces the rational incentive to purchase insurance for that eventuality. And then third, the response of many long-term care insurance companies in response to these trends has been to increase premiums dramatically on current rate holders and future policy holders. So that tends to drive the market down as well. So it's kind of one of those, I don't want to use the word death spiral, but that's kind of what seems to be happening on the lives here. Yeah. So who's left holding the bag? That's on slide 11, Medicaid. We provide long-term care through two programs, skilled nursing facilities, as well as the waiver, the home-based services done. Which we did serve, do assisted living facilities. Those two waivers merged in 2017. So it's just one waiver that does both assisted living and home-based services. Mr. Chairman, sorry, Senator Hutchings had questions.
Thank you. Franz, my question is on these Wyoming Medicaid long-term care facilities. How do we get ourselves into this where we got pulled into creating these facilities? And now, like you say, we're left holding the bag as a state. It seems like this is the reason why I don't like Medicaid is you get all these promises up front and then you get sucked in and then the floor gets pulled out from underneath you and we're stuck and we keep falling for it over and over and over again. So what was it that drew us into this at the beginning? Just
Sure.
the stories that everybody believed? You're too young to know really, but.
Mr. Chairman, Senator Hutchings, I love history. You know that. Has historically, since the colonial days, been a county and local responsibility. So there were poor houses, and that's typically where people, indigent, elderly, without any family, would be in these poor houses. They were pretty deplorable conditions, and they put everybody in the poorhouse. So there were mentally ill, people with developmental disabilities, orphans, pretty much all of society safety net was in these county level institutions. And over time, there were state institutions like the state hospital that were constructed to take care of people like the mentally ill, the Life Resource Center and Lander for people with intellectual disabilities. But the elderly poor remained in these poorhouses. They were sort of the last population to be taken out. So back around the turn of the century, they were still around in the Depression. They were called rest homes, boarding houses. They kind of evolved over time, but in the 50s and during the Great Depression, they really became medicalized as nursing homes. And the federal government and state governments began taking a much larger share of paying for that. So back in 1950 or mid 50s to the birth of Medicaid in 65, that's kind of when that responsibility became assumed by the federal and state governments as opposed to city and county governments. Hopefully that answered your question.
Yeah.
Okay.
Go ahead.
So you can see enrollment on the next slide. I won't kind of go over that, but the main trend here to note is that our waiver programs have really absorbed the bulk of the long-term care enrollment increase. We have about 4,000 members. There were significant declines due to COVID, and not just due to mortality, but also due to, it seems to be a reluctance to enter long-term care to begin with. Possibly the restrictions that were imposed on nursing homes, the environments that were there made people very reluctant to enter that setting. So we have seen a dramatic decrease in the arrivals to Medicaid long-term care, which is really responsible for this trend in declining enrollment. Slides 13 and 14 are just tables for your reference. I'm not going to read those lines, but you can kind of see our trends and expenditures, our member months, which is the number of people in any given month times 12, because there are 12 months in the year, and then our average enrollment. And then the per member per month is sort of the average cost per member. The important thing to note here between those two slides is that the community choices waiver, the home-based alternatives are dramatically cheaper for the state, around 40% of the cost of nursing home. So we really members generally prefer to stay in their home. The state prefers that people stay in their home as long as possible for that fiscal reason. So it's sort of a win-win for both the people and the
Could
state.
you go like 30 seconds into exactly what that waiver provides and how it works a bit for the committee?
Right. So the waiver is it's a menu of services ranging from home delivered meals to personal emergency response, like the if I've fallen and I can't get up button, to the home modifications, to medical, even like home health, private nursing, that kind of thing. It's a range of services depending on what that person needs.
And Franz, if I can, Mr. Chairman, it is important to note that to qualify for the community choices waiver, what we used to call the long-term care waiver, you have to meet in a clinical assessment nursing home level of care. So it is kind of a diversion or an alternative to nursing home placement. And nursing home coverage is required in all Medicaid programs. The reason we talk about the long-term care waiver or community choices waiver is that waivers are optional for states. Obviously, it's in financial and quality of care interest for us to do programs like that for the waivers, but you do have to meet nursing home level of care to be on the community choices waiver.
So, Mr. Chairman, the next slide kind of shows the percent when you take that percent of people on the waiver over the total long-term care. We're approaching 65% of people being served in home-based settings, which is a great trend. This is kind of the trend we look at when we're looking at cost containment, because the more people we can serve in the community, that limits our exposure really on the general fund and the federal funds.
And again, it's 50-50 federal and state funds for this?
Mr. Chairman, that's correct.
Okay.
I won't go over slide 16. It's kind of an eye chart, but I can get into it. Kind of what we're seeing in these projections. Slide 17, you see our enrollment, right? So CCW is in green, the waivers in green, nursing homes in orange. We're going to see both kind of trend a little bit parallel. This is our kind of projection. The actual enrollment we've experienced is the dark lines, and then our projection we started back in 2010 ran the projection, through 2040, and you can kind of see how well it corresponds to our actual enrollment. So the projection does pretty well at capturing our actual enrollment. The real uncertainty, which we couldn't include in here, is the population trends. So that comes from the census and ANI, and there's no uncertainty built into those projections. And so those shaded regions may be significantly wider based on how much uncertainty there is in those underlying demographic trends. And we weren't able to capture that. But you can kind of see this is where enrollment's trending. Because they are relatively parallel, we expect the ratio of HCBS members to flatten. So roughly kind of end around 65% until 2040. And so all things, unless anything changes, that's kind of how we see our HCBS waiver percent trending. And the main reason there is because the waiver is more suitable, generally speaking, for younger individuals who may have disabilities. As you get older, your care needs increase substantially. And so when we get into the 85 plus demographic, it's much harder to serve them at home. And so as that baby boom kind of moves into those upper demographics, that lower kind of percent being served in a home-based setting by demographic affects the overall projection. And that's the reason why it's flattening out, or will flatten out, absent any other policy intervention. Now, on the cost side, the per member per month cost side on slide 19, this is how we project the costs going on an individual basis. And these are generally, it's pretty bumpy. And the reason is because typically these cost increases happen due to legislative appropriations. We come to you for rate rebasing for nursing homes, for example. You may approve or deny that rebasing. And if it's approved, you'll see our per member per month cost jump because those rates have gone up. In some cases like COVID, there's been more federal money that we've poured in nursing homes for mitigation response, that kind of thing. So there was a little bump in 2020, but basically that trend we expect to continue going upwards. So when you look at total cost on slide 20, we're looking at by 2040 a total cost between the two programs of around $275 million, up from around 125 today.
Is that state fund or that's federal and state funds together?
Mr. Chairman, that's federal and state on an annual basis.
And so divide that in half roughly, and that's what the general fund is covering?
Mr. Chairman, that's correct. And you can see the cost for each program and separately, but the gray is the total added together. And then the dark lines are kind of what our current trends have been. We did this in 2017, as the director mentioned. We previously projected higher costs. So by 2030, you can see the circle there, that hollow circle was around $250 million. COVID really, affected a lot of things, unfortunately. And one of those things was long-term care enrollment. So that has kind of pushed back that cost exposure for about 10 years. Due to the decrease in arrivals as well as the significant mortality we experienced in nursing home settings. Mr. Chairman, inflation is kind of built into the slide 19, the PMPM cost. That kind of is basically the inflation on a per member cost. And Mr. Chairman, my last slide, hopefully I've gone through these fast enough. This kind of pertains to the certificate of need. We thought we could use these projections, say, hey, we project nursing home enrollment. Why not extrapolate based on the total state enrollment to look at kind of, when we did see this decline, right? We've seen this decline due to COVID since 2020, decline in occupancy, but that's going to bounce back most likely. So our current capacity is kind of where the status quo capacity was around the red line. So by the time those projections start creeping up back to that red line would be around 2028. And that would be a time that you may consider there might be a need to revisit the certificate of need regulations just from a pure aggregate perspective, not from any other consideration. So with that, I'm happy to close and answer any questions. I hope that was rapid enough.
Scary. Questions, committee? Seeing none of this time. I think so. There's anything else on the presentation? Otherwise, while they're up, let's just have them talk about certificate of need because I'm optimistic it's 5 minutes.
Mr. Chairman, should be about 5 minutes. On slide 24, there's a few slides there.
I need these slides. Hold on.
We'll give you some background on certificate of need. this is something that many states, if not all states, have had on the books or have on the books at some point. And it really traces back a couple of decades where states put in a provision in terms of capping nursing home or long-term care facility expansion. A lot of that was due to, as Franz mentioned, the preference really going back to the 90s to try to develop home-based care as an alternative to institutional care in nursing homes, both for the cost and the preference of members. And so Wyoming has had 35-2-906 on the books for some time, and it is sort of managed or regulated through the Department of Health through our healthcare licensing and survey office. And essentially what it does is, you can see the language there. It basically looks at the community that a nursing home would be in that might be interested in expanding its bed capacity. And we look in that entire area, I believe it's a 30-mile radius, to see if nursing home occupancy is less than or greater than 85%. If it's greater than 85%, there's essentially a restriction on expanding nursing home bed capacity. If it's lower than 85%, then nursing homes can expand capacity or construct new wings, add new beds, et cetera. You can see on the subsection C there that notwithstanding that certificate of need restriction, any nursing care facility in any 2-year period can increase its bed capacity by 10% of the current nursing facility bed capacity, or not more than 10 beds. So it's not a hard cap, but there is a restriction in the ability to expand capacity. Slide 25, you can see the definition of what that construction area is. Again, 30 highway miles, as I mentioned. And then slides 26 and 27 kind of give you a little bit more background on how they're enforced. So we look at basically an annual average, and it's listed on our healthcare licensing and survey healthcare facility directory, and every year is updated on July 1st. And like I mentioned, we look across the state in those geographic areas on a 30-mile basis if occupancy of all of the nursing homes is less than or greater than 85%. Since 2009, the Department of Health and Healthcare Licensing and Survey has received 18 requests to construct new nursing homes or nursing home beds. 11 of those were approved and 7 were denied. And again, you can see it's pretty cut and dry with what the statute dictates of how we calculate and how we regulate that. 2 licensed nursing homes were approved to increase bed capacity, but only one of them did in that time period. And then one of those nursing homes was approved for an unlimited bed expansion because the occupancy rate was above 85% in that area. So again, to close, Mr. Chairman, the rationale for this in Wyoming and other states that have had certificate of need laws on the books is really the potential for oversupplying institutional capacity versus community-based or home-based capacity. It really does kind of align in the 60s and the 70s with the deinstitutionalization movement. We generally think of that on a kind of behavioral health or mental health perspective, but it was very prevalent, especially as Medicaid and Medicare were coming online, to look at making sure as a country, as a society, we weren't overly relying on those institutions. That's kind of the rationale, in addition to cost containment on the federal and state government side. But the other side of that coin is you can have issues with certificate of need laws. It can overly restrict capacity. For example, you can have a community that let's say has 2 nursing homes. One is very popular, very high quality, and there's a long waiting list. The other might not be so popular and is lower quality, and they're at 50% capacity. Certificate of need law in the language you reviewed here would restrict that higher quality, more popular nursing home from increasing its capacity more than that 10% or 10 bed that I mentioned before. So it really is, it's an interesting policy decision. We wanted to give an overview and let you know how we enforce it. But I know there's been discussions over the years of, is it time to revisit or look at changes or even a repeal to the certificate of need? And again, Department of Health's here to answer your questions you might have about that, and certainly going forward in this topic, engage with you or provide information that you might need to inform those decisions. With that, Chairman, I wasn't as fast as Mr. Fuchs, but happy to stand for any questions.
Any idea how many states still have kind of mandated certificate of needs at a state level now that it's been repealed at the federal level for 30 years?
Mr. Chairman, I know it's more than half. Franz was just telling me, I believe he's saying 35. I don't have any reason to dispute that. We can confirm those exact figures. But over the past 10 years, there's been a lot of discussion in other states on not necessarily just repealing, but amending or tweaking certificate of need laws, given the demographics of the population.
Okay, Representative Ward.
Thank you, Mr. Chairman. Would this be a good time to move that we repeal Wyoming statute 35-2-906?
We'll probably take public comment first, and then I will give you the first bite at the apple for motions.
Thank you.
Any other questions for the Department of Health on either certificate of need or long-term care? Not seeing any. Thank you all for being here. Other people wish to testify on either certificate of need or long-term care issues? Again, this is primarily designed if there are any general areas we want to explore for our next meeting, to give an opportunity to have those requests made at a public meeting so LSO can work on some draft language. And I think Mr. Bully does have, or the Hospital Association and Leading Edge has a draft request in the packet that he may ask to be moved, I'm guessing. Go ahead, Mr. Bully.
Thank you, Mr. Chairman, committee members, Eric Bully with the Wyoming Hospital Association and Leading Age Wyoming. Under long-term care issues and concerns, and if it's okay, Mr. Chairman, Emily Crombaugh from the Board of Nursing Home Administrators should be online.
Keep talking, I'll bring her in and get it
Okay,
right.
she can explain this better than I can, but as many of you know, I work closely with the Board of Nursing Home Administrators. A couple of years ago, we did some statutory cleanup and created the ability for the board to do background checks on new nursing home administrators. We have become aware of an issue in statute that precludes the Board of Nursing Home Administrators from issuing temporary licenses to administrators as they either come into the state or as we have emergencies in our facilities where the administrator goes away and they need someone to fill a vacancy. And so there is a memo, a letter to you along with draft legislation that maybe if it's all right with you, I could have Emily walk you through. And
Sure, and it's on page 47 of your electronic packet, committee. But welcome, Ms. Cronbaugh. Floor is yours if you'd like to talk to us about the proposed legislation to move forward.
Thank you, Mr. Chairman and members of the committee. We hope these are brief changes. You can see the first begins in 33-22-103. And it's just to clarify that the board has authority to issue licenses and temporary permits, and no license or temporary permit shall be issued unless the applicant demonstrates satisfactory evidence of their qualifications. The next change would be 2 pages later under 33-22-108A3. And this would grant the board authority to issue temporary licenses and issue licenses and temporary permits. And the board has authority to revoke or suspend licenses, and temporary permits were also added there. And finally, to add a new section under 33-22-111. And this is to outline the situations where the board would be interested in issuing the temporary permit for those individuals in A who are awaiting their criminal background checks, so that if everything is submitted satisfactorily, and this is the only piece holding them up, they can begin practicing. B would allow for a situation where the nursing home administrator unexpectedly leaves or quits a facility. This would allow the CEO of the hospital or a manager of that system to cover the home until a full-time licensee is found. And C would be for an individual that's completing the requirements for licensure that would need to take their national exam or complete their administrator and training hour requirement and allow those individuals to practice. And that is the bill, or the proposal rather.
Makes sense to me. Any questions from Ms. Cronbaugh on the proposed legislation? Senator Hutchins.
Mr. Chair, either person can answer this. For me, just a slight concern, why you would want to temporarily give a permit to someone before their background check has been, has come back. seems like a lot can happen with an individual in a nursing facility. Something could go awry. Why the rush? If there's a CEO that can come in and just kind of do things that's been with you guys for a while, seems like that would be the better choice to, or you would think he'd already have a background check, he or she, but why the temporary permit? Why such a rush for it?
Go ahead, Ms. Crumbach.
Thank you, Mr. Chairman. And Senator Hutchings, that's a great question. When the board discussed this, they were very much of two minds about this requirement. They ultimately decided they were okay to add this for your consideration because nursing homes also provide background check services for their applicants. And that was their only peace of mind in doing this. I don't know if Eric can better speak to, this was also a request from the practice associations. And so this was compromising language.
Mr. Boley, anything to add?
Mr. Chairman, Senator Hutchins, so in certain circumstances, we may have, so if you have a nursing home that's attached or hospital based, you may have someone in that position that could fill in. And so that's addressed here by allowing them a temporary. In certain circumstances, though, where they're a freestanding nursing home, under state regulations, we got to have someone in that position. And if they've gone through the application process, the background check takes quite a while sometimes. And we actually see delays where we lose not only in this particular area, but in nursing and other areas where we lose the applicants to other jobs because they're waiting so long for that to happen. And so we just felt like this might be a good compromise. I actually precept at times. I still have my nursing home administrator's license, and I precept to help administrators go through the in-training process. And this also addresses that to allow them temporaries while they're waiting to take that test and get the results back. But it's just a matter of filling the needs. And we've seen a tremendous amount of turnover through the pandemic in both hospital and nursing home administrators. And so we're just hoping to kind of get them to work. And I think if we're just waiting on the background check, but they've actually submitted themselves to it, I don't have the concerns that you do. I don't think I'd apply if I knew I was going to have a background check completed. Yeah. Thank you.
Other questions, Ms. Crumbach, on this issue? All right, at the appropriate time, we'll take that motion up. Anything else from Mr. Boley or anything else on long-term care issues or nursing home issues you want to talk about while you have the mic?
Well, Mr. Chairman, if it's all right, I'll just jump into the certificate of need and we can get that sucker wrapped up. So it's an interesting conversation, and Representative Ward's motion is one option. I think Department of Health did a great job of describing certificate of need. I do think there are some issues with the certificate of need, and it's been in place for as long as I can remember. And I identified this earlier on. So with the limitations on what we can do for existing nursing homes to put additional beds in, it's prohibitive. We just built a new VA nursing home up in Buffalo, and it's done in a greenhouse model. Under this, they'd have to have 120 beds, and they would only be able to increase their numbers of beds by 10 because that's the max. But when you build a greenhouse pod, it's done in 12 beds. So you would basically have to build 10 beds, and then you'd have to wait 2 years to put the other 2 in. It creates some issues with economies of scale as we see inflation in cost. In our other facilities, it's the same situation. There may be situations where it makes more sense economically to build out as opposed to being limited to that space. One of the other things that we run into, and it was addressed with certificate of need and the 85% occupancy requirements. We have some really, really good nursing homes in our state, and I worry about repealing certificate of need completely at this point because those nursing homes need protections. And in all honesty, most of them are struggling mightily right now. To open the market up, let's say competition, I don't know how many people actually come into the state knowing that they're going to receive 70% of their patients are going to be Medicaid. But there are some very attractive communities in our state. And I think in the future, we maybe need to look at certificate of need. But I do think that as far as repealing it, and you do have communities where there's only one nursing home, and they may not be the top performer, so they never get to that 85% occupancy level. And it leaves that community in need of something better. I don't know what the right mix is here, but I do think that we should take a look at least the building requirements for additional beds. I'd like to see it. Either we could look at local control and have the county commissioners or whoever it is take a look at those, or a case by case basis where it could be justified why we need to build 12 beds instead of 10 beds. In the greenhouse example would be a good one.
Okay.
With that, I'd answer any question.
Questions on that? Seeing none. Thank you, Mr. Bully.
Thank you.
And we'll do any other public comment before we start throwing bill draft requests out on long-term care or certificate of need issues. Mr. Laycock, welcome to Evanston. Floor is yours.
Thank you, Chairman Committee. I'm Tom Laycock, Associate State Director for AARP Wyoming. We're a membership organization for people age 50 and over. As you guys are kind of working your way towards Saratoga and a longer conversation around long-term care in September, I just wanted to remind you of a couple of different things. First of all, Franz did a wonderful job with this presentation. The part that I really wanted to make sure that you realized was we are getting older faster than any other state, but we're also really struggling to keep our younger generation in the state. That's a problem because in previous generations, the younger folks have a tendency to be caregivers for that older generation. So when that happens, when we lose that younger generation, that burden really tends to fall to the state. In fact, it already is now. You heard 65% of the state's nursing homes are Medicaid right now. And that's probably going to rise fairly significantly, I would think, given the population changes that we're seeing. So I wanted to let you know that overwhelmingly, our members really want to stay at home as long as they can, age in place as long as they can. We did surveying in 2020, 80% of the people that we surveyed older over the age of 45 in the state of Wyoming want to age in place. In order to do that, we'd appreciate your help in continuing to support the community choices waiver, keeping that uncapped. You know, as we talked about earlier, $4,900 per person per month for nursing home care. That number is closer to $1,800 per person per month when you're able to serve those services in the home. We also support the continuing funding of the Wyoming Home Services, which is a program for people before they get to that nursing home level of care. You're really putting off that institutionalization, a little bit akin to changing the oil in your truck. So we appreciate those two things, as well as service providers in the areas of transportation, personal care, meal services. Really, when meals and transportation become an issue for older adults, institutionalization happens pretty quickly. So that said, I would add more to say, but we'll save it for Saratoga as you guys are working your way to the state home.
We're moving east. All right. Seeing no questions for you, Mr. Laycock. Thank you. Ms. Rideout, welcome remotely. Floor is yours. Talking about long-term care issues. Go ahead.
Thank you. Good afternoon, Mr. Chairman and committee members. Thank you for keeping this topic on your agenda. My name is Carmen Rideout, and I'm the Executive Director of the Hub on Smith, Sheridan's Senior Center. I also represent the Wyoming Association of Senior Project Directors, which includes 39 senior centers and community-based service providers across Wyoming. The demographic information that was presented today by the Department of Health really validates what we are seeing across the state in our cities, towns, and communities. The number of people that we are serving and the numbers of people we are unable to serve is growing. And we believe that senior centers are a critical part of the long-term care continuum, and we want to be a part of the conversations as we work together to meet the needs of our older citizens. Investment and continued support of these services makes sense for people on an individual basis and economically for the state. The good news is community-based services are most cost-effective in terms of long-term care, and that's where people want to be, at home and in their communities. Because of this, we believe the continuation of services that are funded through the Community Choices Waiver and Wyoming Home Services are vital in meeting the needs of the growing number of people in our state. And I just want to thank you for your time and consideration of Wyoming's older adults and their caregivers. And we are grateful for your support. Thank you.
Thank you, Ms. Rideout. Any questions? Seeing none. Any other public comment on certificate of need or long-term care issues at this time? Seeing none, we'll close public comment. Committee. Representative Ward, do you still make a motion? Go ahead.
Thank you, Mr. Chairman. I move to repeal Wyoming statute 35-2-906. It artificially controls the market, and I think we would benefit from a free market.
And if you would repeat that, it's 35. I just want to read it to everybody so we all have it here.
35-2-906.
35-2-906. It's under licensing. And that statute.
So letters B and C.
906A, conditions on monitoring or revoking licenses. No license issued pursuant shall be suspended or revoked or have conditions placed upon it. Without giving licensee a hearing, and division suspends admission of new patients to a facility. The facility shall provide an opportunity to abate the condition or conditions which require the suspension of admissions. Is it just B and C then? And so this is just a bill draft request. So the general concept of your amendment, if you would just elaborate a bit more.
Sure. The concept of my amendment is to get rid of certificate of need, the provisions that control the amount of nursing care facility beds that can be built, because I believe that free market should determine that, not the government.
Got it. So if this motion passes, anywhere else that would be affected would be included. Is there a second on that motion? Seconded by Hornock. Discussion. This is just for a bill draft, so it doesn't need to be a lot of discussion, but go ahead, Senator Hutchins.
Chair, my concern is, Mr. Boley, it mentioned that there may be a need for a fine balance between eliminating this statute, this section, and keeping it. I don't know if others heard that and may be concerned as well, but just wanted to know if maybe Mr. Boley can readdress that, go more into detail as to why the complete elimination might be more harmful than good.
Well, Mr. Bully represents a wide variety of nursing home and nursing care facilities, so I imagine he's got some internal conversations going on. Yep. So if you're welcome to bring him back up if that would help you on the motion to whether or not to have a bill drafted. But I don't think he's looking very excitable about coming back, so we'll let him defer, I guess, unless you have maybe a specific rationale. But it certainly will be a topic if the motion passes for him to come on forward in Saratoga. Any other discussion on the motion? President Clouston?
Thank you, Mr. Chairman. I guess philosophically, I agree with the motion. My question would be to the department, as most of the costs are being paid by Medicaid, if we get rid of the certificate of need, what kind of cost would we be looking at as a state when we see a few new nursing homes open up, that kind of thing?
Dr. Johansson.
Mr. Chairman, Representative Clouston, it's really hard to say because I don't know if certificate of need was repealed, if we would see a bunch of new market entrants coming to build nursing homes. It's possible. That's essentially the information we would need to determine, how much more in institutional care and Medicaid reimbursed institutional care we would see. I do think naturally there is kind of a demand check on nursing facilities because of the preference to stay at home and the programs we have for home and community-based services. So it's a difficult question to answer, but again, as I mentioned, that's kind of some of the historic rationale for why states put certificate of need laws in place. Is to cap some of the spending. It's not the only reason, but it certainly is one policy driver. And as I mentioned before, it is a really, if pressed, if you asked Department of Health director, should we do this? I would have a hard time answering that because there's pros and cons, as we briefly alluded to in the presentation, where as Mr. Boley mentioned, you have really good high quality nursing homes where certificate of need, if it's repealed, you could see those new market entrants that might not be as high quality and puts them at risk. But on the other side of that coin, you run into situations in specific communities or situations over time where that limit on expansion prevented, a quality nursing home from growing. One idea that we've tossed around as a policy option would be to look at things like a wait list adjusted certificate of need, where you have a natural demand signal, for example, a high quality nursing home that has a historic wait list of over 10, 15 people. We could look into that, help you study that if it would be an option to try to strike a balance. But I don't have a great answer to your question, Representative Clouston, because it's really hard for us to predict or give you good numbers that if you did this, here's what we would see in utilization and cost.
Dan.
Representative O'Hearn, welcome.
Thank you, Mr. Chairman. You mentioned good quality. We all want good quality for our elderly communities. Are we paying the same amount of money to the good ones as we are the not so good ones? And if that's the case, why aren't we helping out the not so good ones? So we have that balance where we don't have any requirements on the ones that are better than the others. Thank you.
Mr. Chairman, Representative O'Hearn, it's a fantastic question, a difficult one. We do, so yes and no is the answer. We do have in our rate model for nursing homes, it's not just, here's the daily rate for nursing homes. There's a multi-factor model that takes into account certain quality measures like the age of the plant, the age of the facility, the acuity of the clientele that are served there. So based on their functional assessments, are you taking a mix of, harder to place clients, higher acuity clients, dementia patients, et cetera. So the rate model does factor some of that in, but it's not black and white. It's not cut and dry where we take a quality measure and say, your rate is half of a good nursing home's quality. It's more nuanced in the factors that the rate model takes into consideration, which happy to provide that to the committee.
Representative Hornock.
Thank you, Mr. Chairman. I'd just like to draw the body's attention in that statute 35-2-906 subsection G says beds constructed at any healthcare facility owned or operated by the department shall be exempt from subsections B and C. So we are legislating private companies in this state statute, but we are exempting state agencies. And I understand there's a lot of nuances. It's not that cut and dry, but state agency is exempt from what we're trying to repeal right now. Makes sense to kind of just level the playing field, I suppose.
Director, that's for like the state hospital and life resource center that operate in somewhat of a similar
That's
capacity.
correct, Mr. Chairman. Representative Hornock, you're absolutely right. So the 5 facilities we operate, State Hospital here, Life Resource Center in Lander, Retirement Center, which is a nursing home in Basin, Pioneer Home in Thermopolis, and the Veterans Home in Buffalo. Yes, the state facilities or state institutions are absolutely exempted from that.
Okay. Still just on that general motion for bill draft. Any other comments, committee?
Mr. Chairman.
Sir, Mr.
just
Bully.
A couple of quick comments.
Yep.
And the battle still rages inside my head. So certificate of need for hospitals was repealed 30 plus years ago. And I think if we take a look at the current environment, I'm not sure that was a wise decision. When we take a look at the cost of healthcare in our state, there are no regulations as far as who can build what and what can open. We've seen hospitals built in Natrona County that have now reverted to hospital owned. They were surgical or physician owned at one point. We have imaging centers that are popping up that are pulling services away from hospitals, leaving the highest cost healthcare in those facilities, but they're cherry picking and using insurance and high payers to sustain their model. So when I look at long-term care, and I'm going to use an example here that Representative Hornock just brought up. So in Buffalo, the certificate of need was not adhered to because it didn't need to be when we built a new VA nursing home up there. We have a beautiful hospital and a nursing home up there that are running at about 2/3 capacity because they can't get staff. We have a beautiful brand new VA nursing home in Buffalo that doesn't have enough staff. And so I do think that there needs to be some measures in place to make sure that existing facilities can take care of the patients in their communities. So I would like to see a more measured approach, and maybe eat this apple a bite at a time, and maybe change some of the requirements for existing facilities to increase their capacity. And I like the weighted approach that has to do with high quality facilities, with a waiting list, get preference over adding beds, and see how this goes. I think this is something we're going to revisit over the next several years as we look at our aging population that we just talked about. I just don't know if right now is the exact right time to repeal it, but I do think that some changes do make some sense. Thank you.
Okay, further discussion on the motion of Representative Chadwick.
Thank you, Mr. Chairman. Director Johansson, have you ever had a situation where someone wanted to bill more than what they were allowed to? And please cite those for us.
Good.
Mr. Chairman, Representative Chadwick, yes, we have. I don't know the specific ones off the top of my head. We can get you that list. I believe since 2009, we've had 7 requests in the certificate of need denied based on the statutory criteria, but happy to provide you with that list. I know Sheridan was one since I've been here, Sage West and Lander. There are a few, but we can get you that list. But I believe 7 total denials in the last 15 years or so.
Okay.
Follow up?
Follow up, yep.
So do you think an increase in that number might be a reasonable?
Good luck.
Mr.
Director,
Chairman,
gonna answer that.
Representative Chadwick, how I would answer that is based on what I see in the data from the requests we've had and the approvals and denials. Generally speaking, over the years, the 10% or 10-bed threshold is usually sufficient for the expansions that we at least hear about or the interest that we know about from actual requests. Now, does that mean that any interest in constructing new nursing homes or new market entrants that we never have heard from, but know about the certificate of need law and never decide to pursue it? Those are things I can't quantify as well. But I would say generally speaking, that expansion that's available outside of the certificate of need is generally sufficient. But those situations that I mentioned, Greenhouse Living of Sheridan is a good one because of that model of care. You can't just expand 1 or 2 rooms like some nursing homes will. The model of care there is very home-based. It's basically a cottage type environment with, a centralized kitchen and dining area, and it's very home-like. So when you build a greenhouse nursing home, you generally build an 8, 10, or 12 bed pods. And in that particular facility's case, the certificate of need law was restrictive in their ability to expand. So I think there's some isolated circumstances where absolutely you're right on point that it has been restrictive and unfortunate. But in general, with the we'll call it, especially over the past several years, the reduced demand that we've seen in long-term care on the institutional side, I think that 10% or 10-bed expansion is generally sufficient. That doesn't mean that certificate of need law is good as it is and doesn't need tweaks. To Mr. Boley's point, I think we should look at those dynamics and look to strike the right balance.
Representative Ward.
Thank you, Mr. Chairman. I'd like to emphasize that this doesn't take control away from the local community, it gives it to the local community. Anybody wanting to build a facility has to convince the local community that it's a good idea. They have to go through the city, they have to go through the county, they have to convince the county commissioners. So this gives a freedom and control back to local control. So I think this is a no-brainer, and even Mr. Boley has admitted it increases competition, which generally is a good thing for the consumer.
Good for kids and education. It's good for old people in nursing homes. Other discussion, committee on the motion to draft a bill. All those in favor of the motion to draft a bill for our next meeting to look at, please say aye. Aye. Opposed, say no.
No.
LSO, if you draft a bill, and I think it's for complete elimination of certificate of need in 906 and associated areas. But I'm certain Mr. Boley and some other people may come with amendments, or if there's a way to narrow that focus and where we ultimately end up. Other motions committee. I believe there's one in your packet if someone would like to move the nursing home training requirements that was discussed. As a chairman, I can't make such motions, but I would leave it up to anybody on the committee if they would like to move that. They're certainly welcome to at this time. It's to do temporary permits. Going once. Going twice. I'm not seeing any motions on temporary permits for nursing homes. So we'll let that one go. Any other motions for bill drafts for our Saratoga meeting that deal with long-term care? Quick question, maybe Mr. Fuchs, or does the money that we put towards the waiver programs for long-term care or for community choices, is that what they're called? Is that appropriations that reviews that number? Or is it just kind of built in whatever? Do you have enough money in there every year? Does appropriations oversee that amount, or is it just kind of holistic on the need on how much money is provided? Anything we need to do in that area to, it sounds like a very worthwhile program. Just making sure we're funding it to the level we need to be. So far, so good. Okay. Anything else, committee? All right, seeing none on those issues. We have 7 minutes to discuss white bagging before we have to go tour the state hospital. LSO, I don't know if you have a bill draft, Ms. Johnson, if you would like to kick us off. I don't know if much has changed with everyone on white bagging and where we are, but any updates?
Mr. Chairman, would you like Ms. Shippen to present her fact sheet too, or just the bill draft?
We love facts. You can both come down. Sure.
Hi, Mr. Chairman, members of the committee. If you'll remember at the last committee meeting, the committee asked LSO to look into the fiscal impact of the 2021 Louisiana white bagging law. And this fact sheet is in your meeting materials. So I did contact the Louisiana Office of Group Benefits that oversees the state employee health insurance in Louisiana. And they said the 2021 legislation has had no impact. The reason being that even before the legislation, the state employee insurance contracts with their PBM did not allow for the practice of white bagging or for the requirement that state employees obtain prescriptions by mail order or from specialty pharmacies. So the 2021 Act didn't change any practice. I also reached out to the Louisiana Department of Insurance to determine if there had been an impact on commercial health insurance sold in Louisiana, and they told me they haven't seen any impact of the legislation on premium rates. So happy to answer any questions.
I guess my quick question is, do they anticipate seeing an impact if we give it another year or so with just, I know it, I think it only went into effect 1.5 years or 2 years ago. Anything that they said, the impacts will start up in 6 more months, but any testament on that?
They didn't indicate that. I have to say, I didn't ask that specific question, but they didn't indicate that they expect an impact.
Other questions in the memo committee? Seeing none, thank you for letting us know and reaching out to Louisiana. I thought there would certainly be, I don't know, some impacts they would discuss and talk, but apparently not. Ms. Johnson, you put together a bill draft for us.
Thank you, Mr. Chairman, members of the committee. This is 24 LSO 25, physician administered medication regulations. This bill draft, and I'll just walk you through the bill draft. First, it contains a purpose section and a definition section starting on page 1. And then starting on page 4, the draft states that a health insurance issuer or a pharmacy benefit manager shall not refuse to authorize, approve, or pay a participating provider for providing covered physician-administered drugs and related services, or condition, deny, restrict, refuse to authorize, or reduce payments for a physician-administered drug when the administration of the drug is a medical necessity and the participating provider obtains that drug from a pharmacy that is not a participating provider in the health insurance issuers network. All payments for a physician administered drug shall be at a rate set forth in the health insurance issuers agreement with the participating provider, or it should be at the wholesale acquisition cost. And then moving on through the bill, a health insurance issuer or PBM shall not require a covered person to pay an additional or increased fee to obtain the physician administered drug when provided by a participating provider. The draft goes on to state that nothing in the draft shall prohibit a health insurance issuer from refusing to authorize or approve a physician administered drug when it does not meet medical necessity criteria. And then the commission of any act prohibited by this draft shall be considered an unfair method of competition and an unfair practice or act. And then also any provision of a contract that is contrary to this draft shall be void and unenforceable in the state. And then I did make one conforming amendment on page 7. And then the Department of Insurance is given rulemaking authority on the top of page 8, and then there's a split effective date. And I would stand for any questions.
Maybe my main question is how is this based primarily on the Louisiana law, and what other stipulations, home cooking as Senator Scott calls it, did we put into it that isn't in their law?
I really didn't change the draft very much. It's pretty much, this is pretty much the Louisiana draft, tweaked just a little bit to fit our standards, but
Okay.
no major changes.
All right, Senator Hutchins.
Thank you, Mr. Chair and Anna. Just wondered on page 6, you talked about little tweaks. Page 8, or line 8 through 13. Nothing in this chapter shall prohibit a health insurance insurer or its agent from establishing differing co-payments or other cost-sharing amounts within the health insurance plan for covered persons who acquire physician-administered drugs from another provider. Does that mean that they kind of can steer patients away from or from another provider to their providers only with financial incentives? Is that what's going on there?
Mr. Chairman, I'm sorry, Mr.
Yep.
Chairman, Senator Hutchings, I'm not entirely sure that that provision is necessarily going to cause any price steering or anything like that. I mean, I think it just allows health insurance issuers to set differing co-payments, but I'm not entirely sure if what you are worried about would end up happening.
Okay. All right, so no other questions. Ms. Johnson, you're off the hot seat. So committee, you remember there was a lot of conversation and consternation on exactly how to get this right, and I don't think we're doing it today. So what I'm, I guess, ultimately looking for are from anyone, or what's the good, the bad, and what needs to really be discussed, and if there's a way to get kind of both sides of the equation to a point where they're, you know, we're gonna kumbaya this to the finish line. I'm not sure we're there, but I would like to hear from anyone on, 30 seconds or a minute of here's what you really need to look at and be concerned with, and then get ready for our Saratoga meeting. Miss Harper, you turned your camera on first, so we'll start with you. If you can do it in about 1 minute, always happy to hear from you. Then we'll go to Mr. Buxton.
Absolutely. Thank you for the opportunity to speak. My name is Lugina Mendez Harper. I'm a pharmacist with Prime Therapeutics, a PBM owned by 19 Blue Cross Blue Shield plans, including Blue Cross Blue Shield of Wyoming. Our issue, there's two core elements in this legislation. One is where you get the drug product, and then the other is where the drugs are administered. Our concern here is that the way this is drafted, that it prohibits us from using licensed, accredited specialty pharmacies to provide the drug product to the clinicians at a more reasonable cost for them to then prepare it and administer it to their patients. And I just want to remind folks, we talked about this during the last committee meeting, that these pharmacies are shipping drugs to providers in the exact same condition and manner that wholesalers and drug manufacturers ship the drugs to the providers. So nothing is different there. But our understanding was that the intent of the legislation was to address safety concerns. We didn't really see any safety concerns in the proposed bill draft. And then certainly recall from the last meeting that the health systems, there were a couple of health systems that testified previously that they've been able to manage this issue via institution-specific policies and procedures. So for that reason, we're not convinced 100% that this legislation is needed. That said, if the committee is inclined to move this forward as a concept, we would just request additional time to engage with stakeholders and have in fact prepared and shared some alternate language for consideration and discussion. So thank you.
Appreciate it. Thank you, Ms. Mendez Harper. And I do think that'll be the plan as we move forward here. Now that there's a bill draft and statutory language, everybody can come together and say, here are the specific issues we have, and we'll see if we can land the plane in Saratoga or not. With that, Mr. Buxton, welcome.
Thank you, Mr. Chair, members of the committee. My name is Jonathan Buxton. I'm with the Pharmaceutical Care Management Association. We're the national association that represents PBMs. I just want to let you know and let the committee know, I know you were made aware of a draft that we shared. We are continuing to work with the proponents of this legislation, and we believe that given time, we can definitely work together to address their concerns about patient safety. And so, given the time constraints that y'all have, we would just appreciate the opportunity to continue working with them and getting some feedback on some alternative language that we submitted to them. So thank you all very much.
Thank you, Mr. Buxton. And we would certainly invite you to our Saratoga meeting in September. You have a large number of fans on this committee who would like to talk to you in person, I'm sure, as we continue to deal with PBM issues as well, which is still kind of in the background and always present. So thank you.
Thank you.
Next up, Mr. Meyer, you want the floor? It's all yours.
Good afternoon, members of the committee. Thank you very much, Chairman Zwanitzer. I am Matt Meyer. I'm a pharmacist up here in Sheridan, Wyoming, and just read through the bill today. Couple concerns I do have on page 4. If we're looking at the bill, line 5, physician administered drug means any prescription drug. I think it might be beneficial, again, with what you're trying to accomplish with this bill, to, after prescription drug, add biologic or biosimilar agent to that line as well, other than vaccines that require administration by participating providers. Since a prescription drug, when we use the term drug, refers specifically to a chemical agent. The second thing, in terms of comments that were just made from Prime Therapeutics regarding limiting access of these medications to specialty pharmacies. The reason why the PBMs are going to be pushing for that is they generally own these specialty pharmacies. And, you know, really what we're talking about there is regulation of the trade of medications, which we are allowing the PBMs to regulate the trade of medications and sales of these medications to provider offices. Pharmacies, wholesalers, we're all licensed distributors. We have separate boards and agencies that are already in charge of regulating the trade of medications into and out of the state for purchase and administration. So I personally would like to see on page 5, removing everything after lines 8 through 11, everything after drug is medical necessity, and change that is obtained from either a DSCSA compliant distributor, or changing that to a licensed wholesaler or pharmacy. Leaving that to non-participating providers in health insurance network, it just seems like we're opening up access to loopholes for insurers and PBMs to mandate where the sale of these medications and limit trade of these medications, where physicians can receive those medications. And then finally, on page 6, this was brought up by Senator Hutchings, lines 9 through 13. Nothing in this chapter shall prohibit a health insurance issuer or its agent from establishing different copays or other cost sharing amounts within the health insurance plan, et cetera, et cetera. The only reason to do that, to incentivize patients financially to receive services from one provider or another, is at the insurance's discretion, at their choice. I mean, again, we come back to patients should receive these services from the provider of their choosing, that they are comfortable with, that they are confident in, and not have, you know, the insurance companies dictating where or not and which physicians can or cannot be included to provide these services for patients in Wyoming. With those comments, I will stand for questions at this time. Thank you.
All right, any questions, Mr. Meyer, Senator Hutchins? And then also LSO, you're kind of keeping track of the comments, and we'll talk about ways forward here in a second. Senator Hutchins.
Thank you, Mr. Chair. That's exactly where I was questioning. He said a lot. I'd like to see some of that maybe amended out of the bill. And my understanding is we can do this at Saratoga. Thank you.
I think what I'm going to ask committee is that we do another similar thing to prior auth, where everybody who has comments in the bill draft can get them to Anna, and then maybe we'll have a small working group and have a semi-public meeting with the stakeholders and try to hammer out differences and see what's remaining. And then we can focus on the 3 or 4 major issues in Saratoga and see if we can move it forward, is kind of my hope and plan. Mr. Schmidt, floor is yours. Welcome. I got you there, Scott. Don't think we can hear or see you quite yet. So while you're loading up, let's try Mr. Hayes from EGI. Welcome.
Good afternoon, members of the committee. My name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program. There is a fiscal impact to this particular program. Let me give you an example. Most of this centers around the fact that restricting the ability to move care to a lower cost setting. These infusions that I'm going to discuss are primarily done on an outpatient basis of a hospital at some fairly extraordinary costs. I'm going to talk about 26 interventions that happened last year, which saved our plan $1.7 million during that time frame. So if we restrict and we don't have that ability to move those individuals to a lower cost setting, the savings goes away. And let's face it, these don't happen everywhere. This is primarily happening in our larger, more metropolitan areas. So I would say Cheyenne, Casper. We're also talking about probably Laramie and maybe Sheridan, where you have some alternatives to an outpatient hospital setting where you're doing infusions. And again, we only had 26 of them and saved $1.7 million. So just wanted to point out, leaving it to where the patient can choose the highest cost setting does impact the costs and ultimately the rates. With that, I would stand for any questions.
Thanks. Questions for EGI? Not seeing any currently. With that, anybody else in the audience wish to testify and just general thoughts on where we're going and how to get there? Ms. Bush, welcome. And then after that, we'll get Blue Cross up here. And then after that, we'll tour the state hospital. Welcome, Sheila.
Thanks. Members of the committee, Sheila Bush, Medical Society. I'll be brief. I think that the Medical Society's largest concerns with all this conversation is diversion of patients away from hospital settings into outpatient settings, similar to what Mr. Hayes just referenced. I think we have a host of problems, especially within oncology. Patients want to receive, and oftentimes their safety depends on receiving those drugs within a setting where medical personnel is available to address adverse events, bad outcomes, et cetera. We don't in Wyoming license infusion clinics. They don't have a lot of regulation around them the way hospitals do. And so there aren't great ways to ensure someone's safety in those settings. I think that the oncologists that have raised concerns with us have mentioned their frustration with being forced to prescribe a medication without any control over how it's administered. If those are administered within their care in settings with their nurses, when they're down the hall, that looks a lot different than writing a prescription for the medication itself and then sending a patient off to go get that administered on their own at an infusion clinic. And so I think, they're concerned about some liability there in terms of not being able to oversee the process from beginning to end. I can speak personally. My dad is undergoing cancer treatment, and he is there in Cheyenne. If he's almost 80. He receives these infusions every Friday. If my dad were told he can no longer go to the hospital that he trusts with a nursing staff he knows, it's already scary enough for my dad. If he were to go into his clinic next week and be told he can no longer come there, but he needs to go to a certain address and get those infusions somewhere else, we would have complete chaos on our hands just at a family level. I recognize this isn't about me personally, but I think it really impacts people at the scariest moments in their lives. And that's just talking about oncology. So as these conversations continue, I'd love to just be involved and make sure that that physician voice gets included as an advocate for the patients.
So, yeah, this specific bill draft, not quite, but the thought of diversion because of it just costs more at a hospital. They have higher overhead costs, certainly. Could be around the clock. It's a slippery slope.
Mr. Chairman, yes, and I wasn't sure if I should testify, but the fact that Mr. Hayes raised this specific thing with how much the state is saving by requiring this diversion obviously sort of compelled me to at least say something. I think on page 5, Romanet 2, you do have this prohibition on conditioning, denying, restricting, refusing to authorize or reduce payment. And then it is around participating providers or physician administered drugs. And so I just don't know where, if anywhere in this language, there lives a provision that would address patient diversion. But that's probably the area of this that you would have the most animated excitement from the medical society community.
Everybody likes animated, excited doctors, right? Representative Ward.
Thank you, Mr. Chairman. Mrs. Bush.
Mhm.
Can you explain to me where in the law it would require your dad to go to somewhere other than a hospital? I don't think that's required here.
Go ahead, Ms. Bush, if you'd
Mr.
extrapolate.
Chairman, Representative Ward, you're correct. So I think because the previous testimony touched on this, I think when you talk about white bagging, you have the practice of white bagging, which is where are the medications purchased and where does the hospital receive them? But you also have this other component of cost savings that insurance companies are employing more and more, just even in the last 2 months. And it's related to not just the physician administered medication, which is what this is about, but also the location where those patients are allowed to receive those infusions. And so I meant to sort of offer the disclaimer that I don't know at this point if this is covered or not, but in the conversation around physician administered medications, it's a component of that conversation that's the most important to the medical society.
All right, thanks. And as Blue Cross comes up here, Mr. Hayes has his hand raised to say a couple other things now that we referenced him. Mr. Hayes, do you have more comments quickly?
Just real
Go ahead.
quickly, there were less than 1/3 of those were cancer. The majority of those are for medical conditions other than cancer. But there was one particular neoplasia was the prescription in case. There were 8 cases on that.
Appreciate it. Thank you. Welcome, Ms. Roday. And then when you're done, we'll go Mr. Schmidt online, but go ahead, Heather.
Thank you, Mr. Chairman, members of the committee. Heather Roday from Blue Cross Blue Shield. Again, we have Raymond Red Jr. With us as well. As we've discussed, we support safety, quality, and timeliness of infusions for our members, and safety is of paramount importance. We want our members to receive safe care to address their health concerns, but the cost impacts are not to be ignored. The bill that we have in front of us doesn't actually address much of the safety that we've talked about. And so in your emails, there is, as has been referred to earlier, alternative language. So We'd really like to continue having this conversation because not all of the stakeholders have had a chance to review that language. And the other problem with this bill is that we're concerned about the message that it sends to smaller providers, such as infusion centers, physician offices, and home health organizations who are in the Wyoming healthcare system. It only suggests that large entities are qualified to administer these infusions when other alternate sites provide equally safe, quality, and timely care for a lower cost. So happy to keep this conversation going and look forward to doing so between now and Saratoga. Thank you.
Thank you. And so again, it is still tangential on patient diversion to cheaper. I mean, can you provide the same service for a cheaper price? In some cases, the answer is probably yes, right?
Mr. Chairman, the answer is yes.
Okay. Okay, Mr. Red, other things to add?
Thank you, Mr. Chairman. Nothing for me to add, but I will stand for if there's any questions.
Mr. O'Day didn't mention Mr. Spencer as part of Blue Cross Blue Shield, but jumping in on the
Mr.
insurance stuff.
Chairman,
Go ahead.
I snuck in. Bruce Spencer representing the Mountain Health Co-op. Mountain Health Co-op shares Mr. Hayes' concern. The bill does have language in it which prevents location being used to determine the medical necessity of the infusion. And basically that eliminates the ability to encourage competition among the places that are going to infuse the drugs. We believe it's perfectly safe to use alternatives other than hospitals. And if you aren't able to use that competition, the costs can be staggering. Last committee, I mentioned an example of 250,000 using a center that raised to 500,000 with hospital. That was one patient per year. And so that could be exponential. Thank you.
Thank you. Questions in general for insurance, Mountain West or Farm Bureau or Blue Cross? Senator Hutchins.
Yes, Mr. Chair, just want to know if someone can tell me what page they're referring to in the bill about the infusions and.
Oh, go ahead, Mr. Spencer.
Senator, I'm happy to look that up and I'll do it offline because I don't have the page in line. I forgot to make that note, but I will do that and tell you.
Thank you.
Shortly.
And I think a lot of it isn't specific in statute, but it's this, how would we make it work? It's kind of everything that's not said in the bill is the issues that are going on because it's huge amounts of cost for some of these specialty drugs on where they get infused. With that, I said, Mr. Schmidt, you can be next, and we'll go to Mr. Boley after that. Scott, floor is yours.
Thank you, Chairman Zwanitzer. Can you guys hear me now?
We can, and see you.
Okay. Sorry about that. I was having some issues with another computer in the pharmacy. It's been crazy since we've had a pharmacy close here in Cheyenne, and now we're just trying to put a bunch of scripts back into the computer to help patients get their meds. But anyways, let me explain to this white bagging situation that's going on. And more importantly, it's going to affect hospitals. It'll affect hospitals in a big way, to tell you the truth, because in rural Wyoming, if a patient's insurance requires them to use a specialty pharmacy outside that community because there's nowhere else to provide this infusion, then that will come from another agency, from another state, another pharmacy, if you will, that's owned by the PBM. They'll ship it to wherever, to where that patient might be, whether it be in their home, whether it might be in their infusion center. But what happens is it's impeding the access process to good care, because you're taking what time it would take to overnight potentially something, if the weather's bad, might not even show up on time for somebody to meet their chemotherapy or to meet whatever drug they're being infused. And so what they're trying to do is they're trying to outsource it to their specialty pharmacy, have the institution where that patient's at infuse the drug, and then that institution can't bill for their services other than, yes, we'll bill an administration fee, and that's what you get paid for. And so a lot of hospitals will lose their shorts on that, because they rely on that whole procedure to be billed and filled within that institution. And so, yes, it is much more, a lot less expensive to do things in the home. And that's where we've helped out a lot with that, with our our clean rooms and the contracts that we have with the insurance providers to be able to provide that and reduce costs overall to plans as well. And so I ask that be part of the bill that allows those, again, the willing pharmacy to be able to do that meets the criteria, has the clean rooms, has the ability to do those, because that's a huge part of my business. And so that's what's helping me combat some of this PBM issue that we're having on the reimbursement side for pharmacies, as you've heard from all the reimbursements that earlier today, that everybody's struggling with getting reimbursed their cost of their services. So it's not only going to affect me, but this definitely is going to affect hospitals in Wyoming. And I guarantee you hospitals will close very fast if we allow white bagging to happen. And I'll stand for any questions if anybody might have.
Questions, Mr. Schmidt? Not seeing any. Reverend Clausen, do you have a question for Blue Cross? Okay, just because they wanted off the hot seats and you kept them on there, I figured we better go ahead and ask.
Thank you, Mr. Chairman. Have there been discussions with insurance, hospitals and doctors? You know, our initial concerns were how the medicines are handled, timeliness, safety. You know, we hear testimony of wasted drugs sitting in the coolers at the hospitals. You know, I guess I'm looking for solutions when medicine shows up that shouldn't be used, or when medicine's supposed to be there and it's not. You know, how do we take care of these patients? That's really, I mean, all of our goals, whether, you know, right? I mean, from the insurance to the physician to the hospitals, what kind of discussions have been held between the groups to try to solve those problems?
Mr. O'Day, anything?
Mr. Chairman, Representative Clouston, I think some of those were going to be discussed in the alternative language that we had proposed, but we weren't able to get to the stakeholders to have those conversations in time to talk about that. So we really haven't had that conversation yet, but we're certainly hoping to do so.
We're going to have the conversation. I have to have it myself with everybody. We'll find out here. Mr. Boley, we're running a little late, so yeah, a couple minutes and
It'll be quick,
thoughts.
Mr. Chairman. Mr. Chairman, committee members, Eric Boley, with the Wyoming Hospital Association. So quickly to address Ms. Mendez Harper's claim that the drugs are handled appropriately, they're safe when they come in. One of the pharmacists from CRMC that testified last time talked about the waste. He was actually going to be online and show you a visual of that. There are some definite patient concerns here. And that's really what we want to focus on. I think we have a good starting point. I think we need to have conversations and we're committed to doing that, but we aren't at the sweet spot or anywhere close to it right now. And I think that there's going to have to be some give and take on both sides. So we're committed to continuing the conversation. I'll stand for any questions.
Thanks, Senator Hutchins.
Two questions, and this is like to Blue Cross Blue Shield. Does the rate change when a drug is sent to a physician or a pharmacy? Question number one. And it seems like there's a kind of I guess the thought that an infusion center is not as safe as the hospital. Can you comment on that?
Do you want to comment on that? But go ahead and have some thoughts.
Mr. Chairman, Senator Hutchings, I think that the site of service, the site of the location of where the drugs are delivered, there's a different cost structure for how much those drugs cost. And so the rates are different for that because they are billed differently. From a safety perspective, I think that we certainly have providers in this state who are doing it and doing so safely. I think that there are places for sure where folks need to receive infusions in hospitals, in case they don't have experience with an infusion and need to be right there in case something happens. But for those folks that have experience and in an ongoing way, those alternate sites, I think, we think make sense.
Thank you, Mr. Chair. The codes for a medication going to the physician versus the hospital or wherever, why is there a difference? You say, why does it matter?
I'm guessing because some of those places have agreements that, but go ahead, Mr. Spencer, if you want it.
So, Mr. Chair, Senator Hutchings, there's two factors. Obviously, it's the cost of the drug is the big factor. And when a plan can get the drug from a specialty pharmacy that gives us a volume discount, you look at a substantial savings. When you have to purchase that drug from the provider, the facility pharmacy, you lose those savings. And in fact, you incur a substantial cost. So that's part of it. And then, of course, we're not asking anyone to do anything for free. And so we have contracted rates with all of the providers who help with the infusion of that drug, and they are paid for that service. But that would be at the contracted rate. Okay. But the big thing is the cost of the drug. It is substantially less from a specialty pharmacy.
Okay, any other comments? Seeing none. Thank you much. Mr. Schmidt, did you want one more bite of the apple real quick?
Yeah, thank you, Chairman Zwanitzer. I appreciate the opportunity. So let me just restate what I just said, that, you know, you can, to do these infusions, whether at home or in the hospital setting or whatever, you have to meet the certain criteria to meet sterility and compatibility testing and all those kind of things, and microbial testing and those things. So documentation is there. That's fine. I mean, that you meet those, you can pretty much make an infusion or make an IV bag anywhere you need to, so long as you meet that standard of care. Where the problem is again, it's not. I mean, the drug's still the drug. The drug, whether it's $30,000 or $100,000 infusion, it's how it's billed versus, you know, if you want a hospital rate or you want an infusion center rate, that's one thing. And that's totally different because that's different contracting prices based on level of care and services of care, right? But any infusion center, or myself included, has to meet those criteria to be able to do that. And I have the same expenditures as a hospital would to maintain their clean rooms and their IV rooms as well. So again, you know, where it's nice to have access and let patients be able to choose. I mean, it is less expensive to do it in the home, and nurses, you know, are qualified to give those in the home. And we definitely work with all sorts of providers to do that and make sure that it's safely done in the home. And so, knock on wood, you know, we haven't had an issue. So again, to say that, you know, doctors can do it better in the office or it's better done in the hospital, that's not necessarily true. Because, you know, we've proven that. And so it just comes down to having accessibility to what's going on, and the difference between billing a pharmacy claim versus a medical claim is where that reimbursement lies. And so again, if anybody has any questions, I mean, I'd be glad to answer how we go about being certified to do the things that we've done, just to help people understand that, yes, it doesn't have to come from a specialty pharmacy states away, because there is a lot of waste that happens when it doesn't show up on time, or heaven forbid, it went to the wrong address. So again, it's a big deal.
Okay, thank you, Mr. Schmidt. So committee, what I'm going to ask is probably again from anybody who's interested in this to provide comments to LSO Ms. Johnson, whose email, I guess, is it publicly available, Anna? If I have you compile comments.
Yes, my email address is on the website.
Yeah, Anna.Johnson
at wyoledge.gov, yeah.
And so after all those come in, I mean, I know some of you don't like the bill at all, but any comments you wish to provide, and then we'll probably have some type of working group meeting in August. If anybody else on the committee wants to be a part of that, I'll send out an email to everybody. I will probably head it up just because I work at a hospital, and I'm kind of on both sides of it. So one more time. Comments by 10 July, that's Monday, that'd be fine. And then we'll convene probably similar to what Senator Dockstead and Representative Penn did with a working group that we can send the link to certain people. If you want to watch or participate remotely, certainly do that and see if we can hammer out something for this session for Saratoga to discuss. I'm optimistic. So if that works for the committee, we'll just make that so. With that, any public comment today before we break for today until tomorrow? I know Director Johansson wants to talk to us about the tour we have. We are going to have a couple of, I think, bill draft motions at 8:30 in the morning. From either myself or Representative Ward. Might send some emails out tonight, so you're all prepared for some morning conversations. But with that, Director Johansson, we're about to go tour the state hospital. What do we need to know?
Thank you, Mr. Chairman, members of the committee. I'll be very brief. I really just wanted to thank you for taking time out of your agenda while you're here to go visit the state hospital. It's a facility that I'm incredibly proud of, a staff that I'm incredibly proud of. I hope you'll see that today. I talked to Chairman Zwanitzer, and just so you get all of the honest feedback from my leadership and staff there, I won't be joining you on the tour. Spent a lot of time at the state hospital over the years and had the honor of supervising the administrator of the state hospital several years ago. It is an amazing facility that treats a population who's really some of the most vulnerable folks we see in the state. And I hope you find, and I know you'll find today, that whether you have discussions with our leadership, our nurses, our psychologists, our social workers, our CNAs, these are some of the best people I've had the privilege of working with in my time in Wyoming. I'll close, Mr. Chairman, with some unfortunate news, but exciting news for him. Our administrator of the state hospital, Paul Mullinax, is retiring this coming fall after 29 and a half years with the state hospital. And I just have to say about Paul, he is the embodiment of what it means to be a public servant, what it means to dedicate your life to folks who are most in need. I am personally indebted to Paul multiple times for bailing us out, filling in as our interim administrator. I think you'll see today just how much he has led that staff and led that team, really to the point where ever since I've been in the state of Wyoming for the last 10 years, I've never seen the state hospital leadership team and all of the staff at every level of the facility in such a strong position as I have seen right now. So again, thank you for taking some time to visit the state hospital. They're excited to see you all, and hopefully you'll enjoy seeing the fruits of your labor with what the facilities task force originally started, thanks to Senator Dockstead in 2013, who got that task force bill passed by one vote at the Appropriations Committee. It really is an amazing thing that's come out of the ground up there on the Hill. So with that, enjoy your tour, and Mr. Chairman, members of the committee, thank you very much.
Thank you. Representative Ward, question, comments?
Thank you, Mr. Chairman. Just a question, Director Johansson. We will not be required to wear masks during our tour, correct?
Mr. Chairman, Representative Ward, no, and no vaccine requirements for you either.
Okay. So with that, committee, let's recess for the day. I think it's officially like a 6-minute drive. So if you can be there by 3:55, that would be preferable, so we can start the tour firmly at 4. Otherwise, we'll be back here at 8:30 in the morning. Representative Trujillo. The address says whatever Google Maps or Apple Maps says. Do we have an official address for the Wyoming State Hospital? We'll get it to you in just a second. If you don't know, it's right up the hill. Yep. All right, thanks.